Hi, my name is Dr. April Morrison. I am a faculty member in the Graduate College of Nursing at ETSU, East Tennessee State University, and today we're going to be talking about some pulmonary clinical pearls. Specifically, we're going to really be touching on asthma, an asthma action plan. I want to just warn you, I will talk fast, not because I'm nervous, but because there is much to talk about. Some of our objectives today, this is actually from a presentation in which we talk about PFTs as well, which there's another presentation you can find housing that information. But just today, for the sake of our asthma presentation and for time's sake, we're just going to cover the top three, which is going to talk about how do we identify asthma, how do we accurately diagnose it in the clinical setting, and then how do we really work with our patient to complete an asthma action plan. So we have a case study. We have a 6-year-old female comes into the office with a chronic productive cough. It increases at night and is recurrent. Her cough also gets worse with exercise and when she has upper respiratory infections. Growth and development are within normal limits, and she gets a chest x-ray that reveals she's got pretty much normal findings. However, there is some mild hyperinflation. So, as a healthcare provider, what might be her likely diagnosis today? As you may suspect, it is asthma. You may have guessed it only because this is an asthma presentation, but that is correct. She did have some very classic symptoms on presentation today. So what is asthma? Asthma is a chronic inflammatory process. It's important to note what the primary process is because then we can better know what medications to treat it with. COPD and asthma over time will sometimes have medications that overlap one another. However, COPD has a very different process by which it begins. Now, inflammation does end up being a part of the disease process. However, asthma is very different in that chronic inflammation is what begins the whole cascade. Oftentimes, these patients have a high association with allergies. I call it the trifecta of asthma, in that they'll have asthma, oftentimes atopic dermatitis or eczema, and also allergic rhinitis. Asthma can develop before the age of 3 and very often will be before the age of 8 years. Not so long ago, there was this term that was thrown out there called reactive airway disease. A lot of times we would use that term until the child was about 6 or so. I think that's somewhat fallen out of favor in the literature, so you can actually, for the most part, just say that someone has asthma if they have the correct presenting symptoms and meet the diagnostic criteria. Why we're so passionate about asthma is because, as you can see, it results in a lot of hospital admissions every year and especially a lot of ER visits, and that ultimately results in time and money for these families. When we have airway inflammation, we have airflow limitation. In other words, think about a round pipe that is narrowing. That is what we have bronchoconstriction. Along with that, we have an edema, so there's now swelling in the airway. Swelling a lot of times will lead to mucus production. You can actually have the problem with chronic mucus plugging. And then ultimately, if this is allowed to progress and not undergo treatment, we can actually experience airway wall remodeling. So the surface of the airway is actually going to look different. And ultimately, the end game is bronchial obstruction. Now, this is what would ultimately occur, say, if someone went untreated and they had an acute asthma exacerbation. Ultimately, you're going to see bronchial obstruction, obstructing the airway, and oftentimes even chronic mucus plugging that's going to get into the way, and ultimately the body is not able to maintain itself with the airflow limitation and the lack of oxygen, and sometimes patients die. For the sake of time, I'm not going to show you this video today, but this is an excellent video. If you just go to YouTube and type in "How does asthma work?" TED Talk, this will pop up. I put this video on this presentation, and I really encourage you to go watch it simply because we oftentimes need verbiage to use when talking with our patients and their family members so they can understand just how important their disease process is and even to know how to better manage it. Furthermore, if you don't have time in the clinic that day, you can give them this link and they can go and watch the video themselves. Families are very hands-on. Or sometimes what I've done is I'll pull up their phone and I'll bring up the video for them. I'll say, you know what, I'm going to go work on some charting real quick. It's less than a 5-minute video. I'll be right back. It's a great time for you to do some patient education. Now, for asthma, here's a question. All of the following are risk factors for asthma, except. Now, looking at these, we know that cigarette smoking is probably a risk factor. Family history is absolutely a risk factor for asthma. Living on a farm, think about the potential allergens the patient may be exposed to. So yes, that is a risk factor. However, low birth weight is not a risk factor. Oftentimes when we see low birth weight, we may equate that with being premature. Now, history of prematurity can be a risk factor for asthma. However, just simply having a low birth weight does not necessarily pose a risk for the incidence of asthma. So how do we diagnose a patient? Well, there's a few ways we can do it, but primarily we can do it based on clinical diagnosis and symptomatology. Remember, as nurse practitioners, we really want to try to use things that are cheap, that can be quick, and done in our clinic, yet effective. So, symptomatology is a great way to diagnose an asthma patient. Symptoms the patient may present with may include wheezing or cough. They have shortness of breath, especially when they're doing exertion. So maybe the kid plays soccer, or maybe the man works on an assembly line and he's having to exert himself a lot. Perhaps there's chest tightness or pain, and they may even have vomiting related to mucus. So they're going to have lots of mucus production oftentimes as they're coughing. Someone may even say, hey, I'm having a hard time breathing, or a hard time catching my breath. Now, we can actually diagnose a patient based on these symptoms today. However, the gold standard for asthma diagnosis is the pulmonary function testing, or the PFTs. The purpose of a PFT is to determine how bad is the airway obstruction, so what is the degree of obstruction. Also, the PFT can rule out any other lung disorders that may be going on, because as we're going to see here in a little bit, we actually have restrictive and we have obstructive airway disorders. We want to know what exactly are we looking at. How do we know if someone has an obstructive airway disorder? And remember, if we have inflammation and airway narrowing with bronchoconstriction, this is an obstructive airway disorder. The way that this can be confirmed is through the PFT, and what we do is we look at the FEV1 to FEV ratio. That is the forced expiratory volume over 1 second versus the forced expiratory volume over a period of time. And that period of time actually varies based on your age. If you have that ratio less than 0.7 or less than 70% of what is estimated to be your best based on a few factors we're going to look at in another presentation, that means you have a degree of obstruction. So yes, we can diagnose you as having an obstructive airway disease and probably asthma in this case based on that information. Chest X-ray, this is probably not the best way to look at asthma because as you can see, the X-ray is actually going to be normal in about 75% of your patients. You may see if someone does have asthma or wheezing, they may have pulmonary hyperinflation because we're having air trapping going on inside of the lungs, and so you're going to see the angles of the lungs be not as sharp as perhaps they should be. You may see bronchial wall thickening and peribronchial cuffing. This may be a little more nonspecific, but it actually is present in about 48% of all asthma cases. And of course, you may also see pulmonary edema, and this is oftentimes when we have an acute asthma episode going on. You can send these patients to allergists or an immunologist who looks at immunoglobulins. We know that asthma is primarily mediated by IgE, and so it may be beneficial to help these patients reduce their asthma exacerbations based on identifying what are they allergic to and then to rule out any other immunodeficiencies. You can do RAS testing, which is that skin prick testing, to see what they are allergic to. And also it may be a good idea to do a sweat test, sweat chloride, to rule out the incidence of cystic fibrosis. Which of the following demonstrates peribronchial cuffing? Actually, both of these do. If you look where the arrows are pointing to, you will see little circles, little white circles with dark centers. That is actually the peribronchial cuffing that we're seeing. So we have the constriction with air trapping in the middle of it. The one on the right, or image B, it is very small to see, but it is absolutely there. The image of B is a really neat image in that it shows the hyperinflation. So it almost looks like the patient is barrel-chested because of all of the air trapping going on. So classification and diagnosing of asthma. So again, we can look at symptomatology. If you look over on the left-hand side of the screen, the components of severity, these are each of those things that you want to be looking at as you are assessing your patient, whether that be at the initial visit or even in subsequent visits following. So how bad is their impairment? Are they having symptoms intermittently, so maybe less than 2 days a week? Maybe it's more mild, where it's at least 2 days, probably more, but it's not every day. Maybe it's moderate, so they're having these things every day, or maybe it's so severe that they're having it all throughout the day. Are they awakening at night? So that's important to know. How frequently are they awakening at night? If they're already on a SABA or a short-acting beta agonist, are they having to use it greater than 2 times a week? How bad is this interrupting their activity? And then again, if you have access to their PFT test, do they meet the criteria for asthma? What is their lung function at that point? Based on this classification, the patient will be diagnosed as being either intermittent asthma, or they'll be mild persistent, moderate persistent, or severe persistent. And based on where they fall, if you go down to the very bottom where it says recommended step for initiating therapy, that is going to dictate where that patient is going to start in regards to their medicines when they leave that day. When you're looking at asthma, think of the rule of 2s. So every time your asthmatic patient comes into the office, you need to be asking 3 questions. How often are you using your rescue inhaler? How often are you waking up at night? And then how often are you having to refill your inhaler? When the rule of 2s comes into play is, are you using your rescue inhaler more than 2 times a week? Are you awakening more than 2 times per month? Are you having to refill your rescue inhaler greater than 2 times a year? Treatment is actually dependent upon age, and the reason for that is the FDA has not approved all medications for all age groups. So as you'll see on these care plans I'm about to show you, these treatment guidelines, there's not a lot of meds available for the 0 to 4 age category. However, that does go up on there. And we will titrate our treatment based on symptomatology. So how is that patient doing that day? As you're looking up your guidelines, as you want to treat your patients and ensure you're doing it appropriately, please make sure you're looking up here in the upper left-hand corner to make sure you have the correct age category. You want to make sure you're treating your younger children with the appropriate meds. And each of these are the steps that you're going to take. And over on the right-hand side of the screen, this is what you'll be assessing every single time your patient comes in the office. So essentially, it's the rule of 2s. But something else you may want to look at is, are they being adherent to their meds? Do they know how to take their meds? Does the child need a spacer? Are they using the spacer appropriately? Have they taken the necessary steps to ensure that their environment is reducing their allergens? So all of these things are very important. As we step up, you can see 5 to 11, these kids have a little more meds, and then 12 and up, this is 12 through the end of life. This is the care plan that we're going to use in the treatment guidelines for these patients. And again, the step up or step down is needed. And if possible, please step down your patient's medication therapy. Which of the following are potential side effects of inhaled steroids? Actually, all of these are, except for palpitations. And so it's important that we educate our patients before they leave, saying things like, you may get a hoarse voice, or please make sure you rinse out your mouth before you, after taking your medication. The asthma action plan is an individualized plan that you make with the patient that day in the office. It's a great guideline for self-managed care for worsening of symptoms. So patients oftentimes will go to the emergency room because they're having these episodes and they just don't know what to do. But if they had a plan in hand, research shows that they are less likely to utilize healthcare resources. It actually improves their quality of life, so maybe the kid gets to not miss school, or maybe he gets to participate in his athletics, or perhaps that man gets to work his job more effectively. They reduce their utilization of health care. Again, they're not missing school. And actually, all of those who have asthma guidelines, so the AAAI and the Pulmonary Association, all of these people have asthma guidelines. They all recommend that everyone who has asthma have an action plan. It actually can result in a 70% reduction in mortality rate. However, only about a quarter of all patients get an AAP from their healthcare provider. This is an example of an AAP. This is actually from the NIH. You can just Google asthma action plan. There are a variety of different kinds, but they all basically have the same exact thing. You want to make sure that the patient uses what's called an incentive spirometer, and there's a great video that you can do online. If you just Google incentive spirometer instructions, this YouTube video should pop up. But essentially, you're going to have a green, yellow, and a red zone. Within those zones, it's going to tell you whether or not you need to use this medication or not. I would really encourage you to go and look at that video to make sure you have an understanding. And that is all.